Is it turning back on or not? Okay. Yeah, it's okay. I'll just focus on one of them. It has to be no, this is just a projector. It shoots up So you are on the screen here now. So right at 9, I'll have a few comments, and then I'll flip it over to you, Zaina,
Okay.
and then it'll go to you, Lolem. So, okay.
Sounds
See, I'm not
good.
hearing you.
Yes, I'll be ready.
Are you muted, Lolem? Can you hear me, Lolem?
Yes, yes,
Oh, okay, good.
very well.
And Zaina, can we?
I can hear you.
Okay, okay.
Okay.
Have this on. Do you want this on or not? I mean, there's the, this button, the mute podium.
Okay.
Now it's muted if it's blinking. So,
Okay.
yeah, nothing. So up to you.
Oh, it's small enough group that I don't think we need.
Okay. And mostly, it's not mostly you talking, it's mostly them then.
Right, yeah. Hey, Richard, can you sit somewhere in the middle? So they can see Lolem and Jerry can see you. Yeah, it'd be fine, sure.
I don't know if everyone,
Okay.
I want to ask everyone if they can hear if they can hear it, let them know.
Oh, yeah, okay, so, and how do I make it louder?
I don't know if this is going to do much, but let's check the exit full screen for a second. I just wanted to check the. Is this all the way up?
Yeah, it is.
Pretty much.
Yeah. Zaina, could you just say something, see if people can hear?
Yeah, I can. Hi, how's it going?
Can you hear okay?
Hello.
Can you hear the voice?
Can you hear me?
Can you hear it?
Hello, this is Zaina.
Can you guys
Hey,
speak up a little bit?
Yeah, this is Zaina. How's it going? Can you hear me? Hello, testing. No? Yes.
It's like talking to a wall.
Yeah, talk to me, Lolem. I'll talk. Say hi. I know, it's kind of funny.
Can we see the room? Can we not see the? I guess we're not going to be able to see the room now.
The room, I'm not sure. No,
Okay.
I can
What do
see
you
it.
see on the YouTube?
On the YouTube right now, it's what we see now. It's same thing though.
Ah, okay.
Can
Okay.
you hear now?
Yeah, I can you hear us? And then it switches back and forth. Sometimes it's Dwight, sometimes it's you.
Okay. Okay.
Hello, can you hear us? No.
Yeah, so just wait a couple minutes. I'll say a few introductory things and then I'll
Okay.
turn it over to you, Zaina, okay?
Okay.
Okay, so welcome. Glad to see a few of you here. Had some multiple fits and starts here trying to get the live streaming to work. I think it's working okay. Let's see. There is a chat box where people can be viewing this. So hopefully we'll get some.
This is the. Now go.
Hopefully we'll get some comments on the live stream. But in any case, so welcome to the symposium. So we have two speakers this morning. One is just introducing the other. So these are students from the late 1990s. We're both students of Richard. And so Zaina Gawi lives in Wichita, and she'll be introducing our speaker, Lolem Ngong, who is speaking to us from Nairobi, Kenya. So Zaina, go ahead.
Okay, hi. Good morning. It's my honor to introduce a dear friend and someone I admire. Lolem and I graduated from Bethel in '99.
Speak up. Speak up.
Oh, okay. So it's my honor to introduce a dear friend and someone I admire. Lolem and I graduated from Bethel. She welcomed me into her family and community, and I will forever be grateful to have come across someone as kind, intelligent, strong, and confident as she is. While at Bethel, Lolem and I shared many things. In addition to great times on the weekends, we were both chemistry students, and Richard was our professor. If I recall correctly, more than 80% of our chemistry class was international students. I don't know how Richard did it, but I felt right at home in his classes. I understood very early on that Richard is a patient person who can handle a lot. And the best part of it all was that he was still funny and lighthearted in the middle of the chaos. My favorite memories of our classes are of our labs. One incident that stands out was when we tried to agree on a radio station on a radio that felt so old at the time. We were moving the antenna and changing the location of the radio, trying to get reception. And we were arguing on what kind of music would work for everyone. We were all, of course, sharing our deep philosophical thoughts about music in a tone that was a bit on the loud side and probably sounded more intense than was intended. At some point, Richard walked in, turned the radio to a station playing classical music, smiled, and called it good. Let's just say a lot of people got their work done quite efficiently that day. Lolem and I were both international students in Kansas, trying to figure things out, and we had each other's back. After Bethel, I followed Lolem into public health at KU Medical Center in Wichita, where I was able to see her blossoming in a field that seemed to encompass all her strengths. She was a research assistant and finishing up her degree, and she was thriving as usual. She moved on to Atlanta and worked for the CDC as she launched her career in future in public health. I'm very excited to hear about her current work in Africa. Lolem is a seasoned public health professional with more than 15 years of leadership in global health diplomacy and coordination of strategic partnerships to address threats to public health. She currently serves as Chief of Staff at Amref Health Africa. An epidemiologist by training, Lolem has advised and led collaborations with governments, civil society organizations, academic institutions, multilateral organizations, and international donors. I am looking forward to her presentation. So, on to you, Lolem.
Thank you.
You're welcome.
Dwight, can you hear me?
Yes, it seems like we're okay.
Okay, great. Good morning and greetings from Nairobi, Kenya. Thank you, first of all, Zaina, for that extremely kind introduction. I do remember the radio incident. It seems like such a long time ago. So many memories in chemistry lab, and of course, really remembering the just warmth and kindness of Richard, and just all the wonderful gifts he gave us. Some fantastic, aside from our knowledge in chemistry, but I think he also gave us a few tips on just being good citizens in this world. And as Zaina rightly said, we were majority international students, and with all of us from so many different countries, somehow Richard managed to not lose all of his hair and go gray very early, and really made us feel at home. So Richard, thank you. I am extremely honored to speak to my alma mater. I was telling Dwight and Zaina 2 days ago, I've been bragging because everybody else in the office has had a chance to give a lecture at their alma mater and I haven't. So this is really an honor for me, and it's a privilege for me to be able to do so. So I hope you can hear me. I'll take us through a few slides and answer any questions. And I hope it'll be interesting. Just telling you a little bit about the work I do and the organization I work for, and my journey since Bethel. I'll go ahead and share my screen. Can you see my screen?
Yep, it looks fine.
Fantastic. So I thought I would talk a little bit about rethinking Africa's health systems. And this is really against the backdrop of COVID-19. A pandemic that has really disrupted all of our lives and really shaken the world. I don't think there's any corner of the world that has not been affected by the pandemic. So I wanted to talk about just some of the changes that are happening on the African continent as a result of COVID. Some of these are issues that have been there for decades, but certainly now highlighted as a result of the pandemic. But first, I just wanted to spend a few minutes talking about, how did I get here? How did I get to public health? I was born and raised in Cameroon, West Africa, and because of my parents' choice of career, my sisters and I got to travel and live in quite a number of African countries. And that really was my first education ground, if you will. I learned so much just from traveling and living in so many different countries, a lot about compassion, understanding other cultures, being able to adapt easily. And those were just some of the things that moved me to eventually find myself at Bethel College. And so went to school at Bethel, graduated with a degree in chemistry, had not planned to major in chemistry when I came to Bethel. I had planned to major in biology and go to medical school. And along the way, fell in love with chemistry and really enjoyed chemistry, enjoyed every last bit of it, except for organic chemistry. But aside from that, enjoyed chemistry. And so I was on this path to go to medical school, but I think at the time, it was because my mother is a physician. So I felt the need to go to medical school. And along the way, realized my senior year, that medicine was actually not really my passion, and I needed to find something else. And I happened to stumble upon public health. And so went to KU, as Zaina said, and at KU got my master's in public health and concentrated in epidemiology. And I think I chose epidemiology because of it's really, for me, the bedrock and science of public health. I think all the other branches of public health are very much social science. And epidemiology really spoke to me because I call it the pure science of public health. And it reminded me, some of the skills and the practical sense of it reminded me so much of chemistry. So after graduate school, went on to work at the US CDC as an epidemiologist for quite a number of years. But I always knew that I would come back home. And it didn't matter to me if it was Cameroon. When people ask me where I'm from, I usually say I'm a citizen of Africa because I feel at home in any African country. And so I knew I was going to return to somewhere in Africa. And that somewhere, after so many years of being in Atlanta at the CDC, that somewhere happened to be my first entry was Kinshasa in the Democratic Republic of Congo. Had never lived anywhere in Central Africa. Well, Cameroon is Central Africa, but outside of Cameroon, had never lived in any other Central African country. And so went on to work and live in other African countries, and then did a very short stint with with Gavi, the Vaccine Alliance in Geneva, and still, I don't know, Africa just kept calling me back. So then I came to Amref, and so my here right now is Amref Health Africa, and Amref Health Africa, we're an international NGO, non-governmental organization. We're based in Nairobi, Kenya, and we've been the business of public health since 1957. So we have quite a number of interventions and health projects ranging from HIV/AIDS intervention, TB, cancer, other non-communicable diseases, and community health systems. The core of our work is really in strengthening health systems so that they're equitable, they're accessible, and they deliver quality health services. That is really the foundation of all that we do at Amref. We have about 1,500 staff. 90% of our staff are based on, yes, right.
Could you just try to speak a little bit louder if you can?
Oh, sure. How is it now? Is that better?
Yeah. Yes.
Okay. Okay, great. So 90% of the staff at Amref are on the African continent, but we have offices all over the world. So we have our office in the US is in New York. We have an office in Canada, and then we have 8 offices across Europe and also UK. We also have some social enterprises. So one of the things that makes us really unique is that while we deliver health services, or we strengthen the health system to deliver quality health services, we also have a social enterprise arm. And that social enterprise arm, there are 3 prongs to it. So one is a university, and it's a health science university. Then the second, and the health science university is really our contribution to increasing the health workforce across the continent, the African continent. Then the second social enterprise is called Amref Health Innovations. And what we do is that we look at some of our innovations in, let's say, training community health workers to teach or engage communities around HIV prevention, for example. If we look at some of the tools that we use, and if those tools are scalable or if those tools are marketable, we then bring it into Amref Health Innovations, which is sort of our lab. We use that to really look at technology, look at delivery of digital health, and look at how we can expand some of our health interventions using technology. Then the third of our social enterprises, which is really where our history lies, is in flying doctors. So our flying doctors affords us the ability to own a fleet of jets, which deliver health service to really far-reach places that may or may not be accessible by road or might take too long to reach. And so we reach some communities that are quite far in the hinterlands using our flying doctor services, and we also do medical evacuations. So in summary, just regarding Amref, not my lecture, our business is in human resources for health and innovative health services and solutions, and in helping governments, African governments, invest in health. And so when I say the core of what we do is in health systems, our goal really is to ensure that good health and well-being is available to everybody on this African continent. And so all of our work is built around how do we ensure that healthcare is accessible? How do we ensure that healthcare is affordable on the African continent? And so we've been going on and on doing all this work for the last almost 60 years, and then COVID hits. And so this picture on I think it would be the left side of your screen, is just one of our planes, our jets, delivering services during COVID. And this is in the northern part of Kenya. So when COVID came, as I said, it disrupted all of our lives, and we had to really rethink delivery of health systems. And so just to give you an idea, so on the African continent, as of this morning, 8.3 million people were affected with COVID. Now, I know when we think about this in relation to other countries or other continents, it's quite low, but we do know that our numbers are grossly underreported. We've had quite a number of recoveries. Our deaths are estimated at 200,000, but we know they're probably more than that, because if you look, even just looking at the bottom, the number of tests, we've only done about 72 million tests. Now, if you compare that to the US, we are thousands and thousands of miles behind. So our numbers are not truly reflective of the COVID situation on the continent. Nonetheless, we did prepare quite significantly. We did put together a very robust COVID response. And when I say we, I just mean, the joint response across the continent. And this was led by the Africa Centers for Disease Control and Prevention. So this is our version of the CDC. They're headquartered in Ethiopia, in Addis Ababa, Ethiopia. And they mounted this really big joint response to COVID around with 3 pillars: preventing transmission, preventing deaths, preventing social harm. Because of course, and I'll go into this a little bit, we know that COVID has really, across the world, has really been driven by a lot of misinformation. So this 3rd pillar of preventing social harm really looked at risk communication. How do we counter some of the, excuse me, some of the false information that's out there, whether it's about the history of COVID, the spread of COVID, and also about vaccination. So these 3 pillars really governed or really guided Africa's response to COVID. And so, at Amref, what we did was that we said, well, COVID, while we're responding to COVID, we also need to ensure that routine health services are being delivered. So at the start of the pandemic, we realized that there were some women, for example, pregnant women, for example, who were not seeking antenatal care just because, people were afraid to go out. People were afraid, especially to go to hospitals, just fearing that, that's probably one of the places where you will, contract COVID. And so we came up with, I'll just talk about maybe 2 interventions. We came up with this called Wheels for Life. And this is in collaboration with one of our hospitals in Nairobi. And it was really, it's sort of a hospital on wheels, right? And so pregnant women would call, and a service will be delivered to them. So the doctor would come or a nurse will come to check on them. If they went into labor, there would be a community health worker and a midwife, for example, that will attend to them, make sure they get to hospital, and so on. And then we even explored, there's some African countries, for example, Ghana, Rwanda, that have used drones to do sample transport of lab samples, and to also help raise community awareness. We've also done a lot of mobile-based training of community health workers. So this is where we've, instead of doing face-to-face trainings of healthcare workers, telling them about COVID, prevention of COVID and so on, we've done this on just using mobile apps. So these are just examples of some of the things that, excuse me, we contributed to in terms of COVID response. But in doing all of this, we also realized it's just not about the virus. So while our energy was so focused in combating COVID, there were so many other parts of the sector, other parts of life, if you will, that were also struggling. So unintended pregnancy. So we had, in most African countries, either went into a full lockdown, so limited service, or they had a curfew. So for example, in Uganda, schools were stopped. And I think that was similar in some parts of the US. In Kenya, we had a 7 p.m. to 5 a.m. curfew. No schools, all restaurants closed, all businesses closed, only essential services. Very similar to what happened in some states in the US. So as a result, kids not going to school, we started seeing some unintended pregnancies. We saw, of course, an increase in poverty because people are not working. So people are not earning an income. And unfortunately, the larger percentage of Africa's workforce is really informal labor. And so we also started seeing the effects on mental health, as we've also seen across the world. So what this really meant for us as well was to look at just the situation of our health systems, because we also started seeing an overcrowding of our health systems, shortage of ICU beds, shortage of the health workforce as well, or let me say inadequate distribution of the health workforce. We currently have had a shortage in oxygen in some countries on the continent. And all of this speaks to the type of health systems we have. So our health systems are extremely fragile. We've always known this, but this really has been a really, really difficult test of the health system, and we failed in that test of the health system. So, and so coupled with all these other social factors is also the fact that vaccination rollout has also been extremely slow across the continent. So while countries are coming back, and I was just in the US in July, and I was shocked, when just going out and about, and people didn't have on masks. Well, the US is coming back. You're building back better, and you're getting there. Meanwhile, there are countries in Africa where we still have to ensure that even when we're outside, we're wearing a mask, we're washing hands. So we're still back. We still have extremely strict public health measures because we don't yet have a vaccination coverage that is as advanced as the rest of the world. Our vaccination coverage right now in most African countries on average is at 3%. I believe the US is already at above 50%. There are some parts of the world that are at 80%. So I put this up here just to make a point that, for the rest of the world, there are 26 doses administered per 100 people. And in Africa, that's 2.6 doses per 100 people. That just gives you an idea of how far behind we are with vaccination. While most places will reach their vaccination goals by mid next year, we will most likely reach our vaccination goals in early 2023. So what this said to us was, we really, really needed to rethink how we get here. So remember at the start of my talk, I'd mentioned at the core of what we do is to ensure that there's equitable, that we have equitable health systems, and that healthcare is accessible to all and is affordable. But COVID has set us back quite a few years. It's also reversed some gains that we've made in strengthening our health systems. So we had to start thinking about, well, how do we still stay on track, or how do we catch up, knowing that, the pandemic is not yet under control, vaccination is slow. How do we still ensure that we're building strong health systems for now and also for future pandemics? So I like to say we're building health systems that are pandemic proof. So that's where this idea of a new public health order to tackle infectious disease threats came up. And really, this is the baby and the vision of the Africa Centers for Disease Control and Prevention. So we can't take credit for it. I can't take credit for it. And the new public health order really looks at how do we strengthen our public health institutions. I've been extremely blessed and privileged to have worked at one of the best public health institutions, this US CDC, and to not have a similar public health institution in almost every African country is certainly a problem. So the new public health order calls for us to build very strong public health institutions, and that means ensuring that we have emergency response operations, which a few countries don't have, be able to conduct surveillance, able to share data, have strong data systems, and also just being able to conduct epidemic intelligence as part of our entire health system. Then the second one calls for a strengthening of public health workforce. And this ranges from epidemiologists to first responders, and also to the physicians who treat people when they fall sick. If just to give you an example, we have on the continent, I just heard this in another lecture yesterday, about 2,000 epidemiologists, I believe, and across a continent of 1.2 billion people. I mean, that's a shocking statistic. And so this new public health order, we're going back to the basics of what do we need for our health systems to have sustainable health systems. So strong institutions, strong workforce, and then manufacturing vaccines and diagnostics and therapeutics. I think one of the biggest lessons that we've learned with COVID is we have to manufacture. Africa manufactures only 1% of all vaccines. And so 99% of the vaccines that we need and the diagnostics are imported. That is a huge economic burden on every single African country. And worse than that, in a crisis like the one we have now, we have to rely on so many other countries to manufacture vaccines. We have to negotiate with so many manufacturers in order to get vaccines to the continent. So we've looked at, how do we manufacture vaccines? How do we work with existing manufacturers to build capacity in certain hubs across the continent to be able to manufacture their vaccines, so that in the case of a crisis, we are also able to manufacture on the continent and ensure that vaccines get to people faster than what we're seeing now. And then the last one is really around partnerships. I think one of the biggest lessons too, excuse me, that has come out of this pandemic, well, we're still in it, is the importance of partnerships. And a lot of the successes that we've seen have been as a result of our collaboration with academic institutions, with private sector, and also with the faith community as well. So it's this really beautiful dance of all these different sectors that have come together with their ideas and really contributed to the COVID response. And so this is really our path to building back better, bolder, and bigger. So I've talked about the importance of health systems and the importance of having strong health systems, and that being the core of the work that we do at Amref Health Africa. And I've talked about that, really against the backdrop of the COVID pandemic, because global health security has always been top of mind, I think, in every country. The global health, for example, I know in the US, global health security really was in the limelight about 10 years ago, right? And so there's a whole very robust global health security agenda that the US CDC implements. And so when we think of global health security, as we think of a new public health order for the African continent, we're ensuring that it's built upon equitable and resilient health systems. And it's built on that triangle I've showed twice already on universal health coverage. So quality, equitable, accessible healthcare. And so when we talk about universal health coverage, what do we mean? It's service delivery, it's a strong health workforce, it's health information systems, it's access to essential medicines, very strong financing. So these are the investments in health, and also leadership and governance, whether it's from a presidential level to State Department, all the way down to local government. These organs are extremely important for us to build resilient health systems, which hopefully will get us to a point of access to healthcare. So I'm hoping I didn't speak too fast. And I thought I would end on this slide, which is sort of my ode to Bethel. Obviously, it's not really a poem of any sort, but I wanted to end with really what I have learned most and what I have kept, the part of Bethel that I have kept with me till this day, and the part of Bethel that I am endlessly grateful for. Bethel for me was my science training ground. And Bethel for me, being a liberal arts college, also gave me the freedom to not just think of science and focus only on science. It gave me the freedom to focus on science, but also, be exposed to classes in religion and psychology, and to do all these other, to have access to so many different bits of social life as well. And so I call Bethel was my training ground, my ground for experimenting, and I'm always grateful for that. And there's so many lessons that have stayed with me. Bethel also really gave me so many one-on-one lessons on communication. Even till this day, when I write emails, I'm reminded of one of my first comms classes, and I remember the professor saying, whatever it is you're asking for in, whether it's a letter or a request to someone, it should be in that first paragraph. It shouldn't be buried somewhere else. And I find myself, even when I edit the work submitted to me by any of my mentees, I'm always looking for, well, what's the ask? I don't want to get 5 sentences in to find the ask. What's the ask? And so there's so many lessons in communicating that I've kept with me from Bethel. Bethel made me curious. Science made me curious. That's the gift of chemistry. It made me curious about so many things, and so that curiosity has stayed with me. And I think that curiosity also influenced my choice of epidemiology within public health, just to know, how do things work? When there's a disease outbreak, why? Where did it start? And how do I track it to the source case? And then how do we stop that disease outbreak? That's part of the curiosity of science. And I put science in 3 exclamation marks, because I think everything I learned, whether it was through communication, curiosity, my training ground came through science. Probably, if I think of the places I most frequented on campus, it was the Crable, the Science Center. So the Science Center, I was also a lab assistant, so I was always in there. Obviously the dorms, and then the dining hall. I think those were my three most frequented buildings on campus. And so for me, the science building was home, because it was where I came alive. It was where I got to experiment. It was where, Richard, you gave us so much leeway in the lab. So thank you so much for that. And lastly, Bethel gave me community. I made really fantastic friends at Bethel. And, the international student community was just amazing. And the care for international students and the guidance provided to international students, knowing that we had come from so many different countries, and would come into this very unfamiliar place, and just helping us adapt to life in the US and giving us some really essential life lessons. So with that, I thank you for listening to me. I hope you heard me. I hope it was exciting. And please ask me any questions. I'm happy to clarify any parts of this talk. Thank you.
Lolem, can you see your audience a little bit?
Yes, yes.
You see Richard?
Yes, I do.
Great. So, any questions for Lolem? Anyone? Zaina, do you have any questions that were in the chat box?
I don't see any. Sorry. I don't know. Sorry.
Can you hear me? Why don't you come up, Pablo? Pablo Ceres has a question.
Hi, Lolem. It is so good to see you.
Goodness, wow. Hi, Pablo.
So good to see you. Such a good talk. Thank you so much for speaking to us today. I was wondering if you could touch on how the differences in Africa between the more city areas than the rural areas, and how those challenges present, because I'm presuming that rural areas in Africa are well isolated. And so I wonder what kind of challenges that brings you and your organization versus what you may see in a city. Again, thank you for your talk. It is fantastic to see you. Thank you.
Thank you. Very good to see you, Pablo. Yeah, I think thank you for that question. It is, as you rightly said, it is a challenge. So, for example, maybe I'll just use vaccination as an example. We've estimated that we have about a 75% acceptance rate of vaccination, of the COVID vaccination especially. The thing is, by nature, Africans are not anti-vaxxers. I think we're the most vaccinated people on the face of the earth. I mean, we're very religious about childhood immunizations. So, but the issue we have, which Pablo is raising really, is that we do have an inequity even within countries. So when we look at vaccination, for example, we'll find out that about 60% of those who are vaccinated are in the cities. And then, the rural areas, and because they're so sparsely populated and they're so far out, we can barely get services to those areas. So one, there's some of the challenges. There's some innovation even around delivery of health services. So there's some governments that have done sort of these, they do really big community outreach days when, you know, they'll basically parachute in doctors and nurses and do basically wellness days and do all the checkups and so on. And then the serious cases would have to be evacuated to the nearest well-equipped hospital. And then some of the other challenges are, you know, by the time some of the rural areas are factored in to, you know, sort of the local government planning, there's some of them that are really just forgotten. You know, and then also because for some of the rural populations are nomads. So, you know, they're there during the farming season, then they move somewhere else. So by the time you get to wherever they are, they've moved to the next place. Or because of the weather, they might move into the mountains. And then, you know, when it's a little bit warmer, they come out and move into the valley area. So even in the design even in the design of health systems, we also have to think about, you know, how do we also follow these very mobile populations? The other challenge related to rural areas, but mostly rural areas that are on the border with other countries. So the one thing with African countries, our borders are extremely porous. So, you know, in delivering health services, so an example would be, let's say Kenya and Uganda. The communities that are around that border, you know, to them, they're really not Kenyan or Uganda, they're just their community. So then in planning even for government, it's a bit challenging because you count your population, but then you also have to count the possibility of the population from, let's say, Uganda, that's gonna cross the border almost every day, whether they're trading or coming in to access services and vice versa. So there are those challenges with following transient populations, challenges with making sure these populations are always counted, rural populations, farming populations, and also a challenge in how do you deliver and sustain health services, right? I don't think we haven't explored, particularly with the health workforce, we haven't explored incentives. And I think that's something we'll have to look at. You know, for example, I know when I was still at KU, there were some medical students, some medical doctors, first graduates who did their rotations in very rural parts of Kansas and, you know, got, you know, medical school paid for as a result. So those kind of incentives we haven't explored, whether it's an education incentive, whether it's an increase in pay incentive or cost of living allowance incentive. These incentives, there's some countries that haven't explored that. Thank you for the question, Pablo. I hope I answered it.
I have a question. Where do they get financing?
Yes, Richard.
Where does your financing come from?
Yes. It's a mix. So we do get a lot of the NGO arm of our organization gets a lot of its finance, probably about, I think the last I checked, maybe about 40% of our financing is actually from the US government. So it's through grants with USAID, with US CDC and US CDC. We also do get a lot of funding from foundations. So the Gates Foundation, we recently got funding from Skoll Foundation. So there are a lot of foundations that we work with. And then we also get quite a lot of funding from government. So the government of the Netherlands, we get quite a lot of funding from the Netherlands, from the UK, and then we get a significant amount of funding from private sector, from Coca-Cola Foundation, GSK, Philips. Our funding is very, very diverse, and we've purposely kept it that way so that we're able to do a lot of the work that we do. So, you know, I mean, the US government may want to fund only maternal and childcare type interventions. Well, we can look to Philips to fund some of our innovative work. And then our social enterprises. So the way that we're set up, which is a bit unique in a way, and I think the only other NGO that I know that has this model is BRAC, in that the way we're set up, our social enterprises also bring in an income, and that's really our unrestricted funds. And those funds we use to do some of the things that are not really restricted by donors. So that would be, you know, if we want to provide technical assistance to governments, and we use unrestricted funds. If we want to, we even do secondments. So there's some African governments who would ask us to do direct in-person technical assistance. So some of our staff sits within ministries of health. In Kenya, we have 3 staff who sit within the Office of the President, working with him on his health agenda and on his gender agenda. So yeah, so our funding is extremely diverse, which also has challenges in keeping up with so many donors and being able to please so many diverse donors. I mean, the European donors are quite different from the US donors. And so, you know, making those adjustments can also be a challenge.
Thank you.
Thank you, Richard.
I had a quick question, Lolem. If you were to pinpoint your biggest obstacle to getting vaccine, would it be amount of vaccine? Would it be healthcare workers administering it? Like, what would be your bottleneck, pretty much, I guess?
Yeah. Our biggest bottleneck is actually access to the vaccine, right? So to date, Africa has received, I think we are now at 185 million vaccines received. And we started vaccinating in, I want to say, April of this year. So we're talking, what's that, about 6-7 months in, and we've only received 185 million vaccines. Out of that, 80% of them have already been administered. So the issue really is vaccine access. And it's really quite alarming. You know, if for those of you who watch CNN International, our CEO has been extremely vocal about vaccine injustice in several interviews on CNN and on Sky News. And we've really been pushing for rich countries to stop stockpiling, to stop hoarding vaccines, because when they do so, then African governments can't even buy the vaccines that they need. So we're hoping that with the G7, G20 meetings coming up, this will be a really an important agenda item, ensuring that there is reduced stockpiling, there's reduced basically reservation of vaccines, so that other countries can have access. President Biden actually had a global COVID summit, I think it was last Thursday, and we were invited to speak at that summit. And it was really fantastic for the US government to pledge to, you know, providing vaccines or to providing or giving up some of its share of vaccines, so that other countries around the world, not just in Africa, have access to vaccines. So vaccine access is our biggest issue. And we know that it is because once the vaccines get here, within a matter of weeks, we've vaccinated. Thank you, Zaina.
I had a couple questions actually about your time here at Bethel. So I'm a chemistry major too, and I was just kind of curious what your research project kind of focused on, either here or possibly at KU. And then I also am just curious, like if you're involved in any athletics or clubs during your time here at Bethel.
That's a great question. Let's see. So my research project, unfortunately, I do not remember my research project, my research thesis, and I don't remember. I'll have to look it up now. Sorry, Richard. I'm sure it was brilliant, but sorry, I don't remember. And then for my master's thesis, my project was on knowledge, attitudes, and perceptions around basically around sex and HIV among young people, among adolescents in Cameroon. And I spent probably 3 months in Cameroon a month in Cameroon gathering data on just people's knowledge, young people's knowledge, what were their attitudes and behaviors as well. And this was, excuse me, and my cohort was a mix of, young people who were in school, young people who were out of school and doing nothing, and also young people who are attending faith-based schools, and comparing those to see if, does it make a difference if you are in a Catholic school, a Catholic boarding school versus a public school or any other private school? Does it make a difference if you are 16 and homeless? Is your perception of sex different? So those were my projects. While I was at Bethel, I will say I was involved in zero athletics. It is one of my regrets because I was very athletic in high school. Then I don't know what happened when I got to Bethel. My younger sister also went to Bethel. She was athletic. She was on the soccer team. So I can take partial credit for that. I was in the international club. I was also in the, I don't know what it's called now, but we had a sort of a career club or something. I don't remember the exact name. I think those were the two clubs that I was involved in, but I was very active on campus. I mean, I aside from being, I remember at one point, aside from being a lab assistant, I also worked at the concession stand because I love sports. So I worked the concession stand during basketball and football season, and also was a waitress and worked at the snack bar on campus, and and also did some volunteer work, but never got into athletics, unfortunately.
Any questions?
I'm Janet Both, chemistry major, 1963. And I want to know, how did you find Bethel?
I found Bethel, so at first, I found Bethel to be extremely small. And let me qualify that. Before coming to Kansas, the last stint of my parents kind of, bumping around Africa was was actually in Ethiopia. So my parents were in Ethiopia. My sisters and I were going to school in Kenya, and we're going to boarding school. And we were in Nairobi, and Nairobi is extremely vibrant. I mean, it's a big city. It's we were very independent, at 14, 15, hopping on the bus and going places and just going about life. And it was it's a city that's constantly buzzing. And then I landed in Kansas and then at Bethel. And I thought, oh my gosh, this is so small. What am I going to do here? And so it took some time to adapt. But what I love about the coziness of Bethel is that I love that my professors knew me, I knew them. I loved that I just wasn't a number, in some of the really big universities, you don't get that, you're not as intimate with your teachers, with your professors. So I really liked that I could explain my idea, we could talk through my ideas, I could get help when I needed help, and I could get the support I needed. So I absolutely loved that about Bethel. I also loved the attention, as I mentioned before, and I think Anzena alluded to this, that Bethel gave to its international students. And I don't take that for granted because, this is a small Mennonite school in the middle of Kansas. You could very well, Bethel in its culture could very well decide, we're not going to provide this enabling environment for international students. But I think Bethel was very intentional about providing this enabling environment. We had an international day, which I don't think any of the other small schools had. We had a wonderful international student guide, Lois Decker, who opened up her entire world to us. And then I also liked that while Bethel is a Mennonite-based college, or I didn't feel the pressure to have a certain set of beliefs or to conform. I felt the freedom of expressing my religious beliefs as I chose to. And I felt that there was an acceptance of oneself. So that's I don't have anything, and I'm not saying this just to be polite. Really nothing negative. Bethel allowed me to grow. Bethel allowed me to thrive. My younger sister went to Bethel. I have a cousin who came and went to Bethel as well. And I love the fact that, if there are few people that I can still call, and they'll remember my name. They'll ask about my sister Aisatu. They'll ask about my cousin Edmund. So it's a fantastic family to have. And to even know that, Dwight was able to track me down thousands of miles away, and ask that I give this lecture. I think it just speaks to this very wide and expansive Bethel family.
Any questions, anyone?
I'm excited because I got a message on YouTube question. I don't know if we have time, but I'll just put it out to you. But
Sure.
David Elena Weeby, on the world map of Amref, it was clear that funding is mostly from the global north. How does that affect the emphasis on local control, manufacturing, etc.?
Yeah, so so that is actually I didn't, and David is right, I didn't actually explain one thing. Our offices that are in the global north were originally set up to be fundraising and donor relations offices. And so they were set up to do all the sort of lobbying with governments and other global humanitarian global health assistance programs. And then we were on this end, were set up to do the implementing. I think probably over, I would say maybe 10 years now, that landscape has changed significantly. So what we're finding is that, one, you have a lot of donor organizations, whether they're institutional donors or private donors, who want to give directly. And so they actually would bypass our northern offices to work with us directly. The second thing we're finding is that we're also finding that there's a small increase in African philanthropists. It's not, of course, it's not as refined, or it's not as formal as the philanthropy circle in the US, but nonetheless, it's growing. And so people are beginning to look at, where do they want to give their money, what makes sense to them, what organizations are good stewards of their money. Now, what has also been changing, and I think is the second part of David's question, is that increasingly, beneficiaries of these funds have demanded to be partners. So in the past, organizations give money, we implement, we report back. Now that's changing. There are a few organizations like ours that now say, no, we're co-investing. Because when we co-invest with our own money, which comes from our social enterprises, when we co-invest, we're then able to make decisions in a partnership, right? So then we're able to ensure that we're building our own local capacity. And then also to the second part of David's question, this is really why I said investment. So African governments investing in Africa's health system is crucial, because we can't have a significant percent of Africa's health funded by external parties. It just doesn't make sense, because you will forever be confined to the demands of the person who's giving. So there's also been that change, and you're seeing a few governments. It's still very, very small. It's definitely not where we want it to be, that are making some efforts in investing in their own health. But agreed, this shift from, the global South has to find a way to invest independently in its health system. Yes, it's a global effort, but I think countries have to figure that out. And COVID has been a lesson. I mean, everyone looked inward, rightfully so, because they also didn't have resources. So we also had to look inward. And that's where we've seen a lot of African philanthropists now stepping up to the plate. But we're far away from getting to a point where the majority of funding for organizations such as ours will come from this continent. We're still quite far away from there. And it's one of the reasons why we're putting in a lot of effort into building our social enterprises arm. I know in our wish, if you were, at least my wish, is to get into a point where 70% of our income is from our social enterprise and 30% is from, foundations, trusts, and other external resources. I think that would be fantastic, because it allows you the freedom to make decisions without worrying about, a government's policy or, a government's choice of, of who to source from for equipment, for example. You can just do things the way you want to do in response to the actual needs on the ground.
So it's a little bit past 10. I think we're in the formal part of the program. If any of you would like, Lolem, if you don't mind staying on, if any of you would like to with her directly, that will become, I'll stop the live stream and thank you all for coming, and let's thank Lolem again.
Thank you so much. Thank you.